Thank you so much. Okay, so now we're going to talk about something a little bit different. Dr. Oscar Murillo, he is from St. Luke's University Hospital in Bethlehem, USA. He's a private practitioner for about 30 years, faculty at St. Luke's University Hospital in the Geriatric Division 2017 to present. He was Physician of the Year, Hanover Hospital 2004. I think it's because I'm not sleeping. Okay, he won the Health Heroes Physicians of the Year Award for the state of Pennsylvania in 2011. He developed Hillside Medical Center at 140 square foot facility, which promotes wellness and prevention of illness for seniors. He provides multiple specialty practices, 17,000 square foot fitness center for seniors, an adult day care center, a multi-purpose room for medical lectures and patient counseling, one-stop health care for seniors, giving families an ideal setting for the care of their patients. He is board certified in internal medicine and geriatrics, and the title of his talk is Treatment of COVID-19 in Long-Term Facilities. Welcome, Dr. Oscar. Please take the lead.
Can everybody see my slides?
We can see your slides, but I don't see your face.
You should be able to see my face.
Can somebody see me?
The video on.
Okay, now I do. Perfect.
Okay.
Thank you very much.
Well, I think I'd like to thank Dr. Gustavo Subieta. Natalia, I think you have done a tremendous job in facilitating. Big clap. You have really outshined. And all the great friends that I met at your lectures in high altitude medicine from India. I'd like to thank them for also inviting me for this presentation. So my topic is about caring for COVID-19 patients in the Continuum of Care retirement communities. Now my slides are not moving here for some reason. All right, so basically this is US data. The population over the age of 65 years is basically about 49.2 million in the 2016 census. That represents about 15.2% of the general population. That is, 1 out of 7 Americans are over the age of 65. By the year 2030, 1 out of every 5 Americans will be over the age of 65. So in essence, we're an aging population. Out of that, I want you to look back, and out of that 49.2 million individuals, 2.4 million live in this continuum or long-term care homes. There are about 15,400 federally regulated homes in the USA and 42,400 assisted living communities in this country. So what do we mean by continuum of care? Unlike other countries, I think in the United States, the seniors, as they go evolving, they tend to look for facilities that will take care of them as they age. And this is divided into 3 settings. We have the independent living facilities where people come in and buy into a concept. They will buy an apartment or an independent home within a given complex. And those individuals are usually fairly active and independent of all their basic and instrumental activities of daily living. As they become more frail, they will need more personalized care. So they go into another area where they will also receive nursing care, and they get a little bit more of a closer monitoring of their health. And lastly, we have the skilled care area where people that are basically the long-term users are people that are incapable of really doing some of their independent activities of daily living. Also in the skilled care area, we have a lot of patients that come back for rehabilitation to those units. That means there's some people that have broken their hips, maybe they had some major operations, that they have had increased problems with their COPD, and they're not able to return home yet. So they come back to the skilled care area so they can receive further rehabilitation until they're ready to go home. So what I have seen is basically that for the independent living community and the personal care community, they were able to pretty much control this pandemic quite well. Because in independent living, we closed those units totally. Those people stayed in their apartments or stayed in their homes. And the same way with the personal care, they stayed in their rooms. And we had very little evidence of COVID-19 activity. I think in my facility, in the independent living, we had 2 cases. In the personal care facility, we had 6 cases. But in the skilled care area is where we really saw the problem. And this has been a major problem for almost all of the homes across the country. So if we look at the number of cases now that we have in the United States, it's staggering. The number of deaths up to today, 186,701 people have passed away. And interestingly enough, 40 to 45% of those deaths have come from these long-term communities, like the ones I work with, and mainly from those skilled care facilities. And why do we have such a staggering number? I think there's only 4 countries in the world right now that have more than 50,000 deaths. That's the United States, Mexico, Brazil, and India. Well, I think in our country, I think this type of facilities have tended to this pandemic. They have become easy targets of the COVID-19, especially the skilled care facilities. The other issue was basically that when the pandemic got started in China, we had about 1.8 million tourists come through Kennedy Airport, LaGuardia, and Newark Airport in New Jersey to see the Big Apple. So as they all went into New York City with their viruses and contaminated the city, we had a huge explosion of this virus in March. And Pennsylvania is right underneath New York. So we got the wave of expansion from that pandemic. So if we look at the state of Pennsylvania and we look at the number of deaths that have occurred here, we can see that our peak of deaths come from ages 85 and above here. But you start seeing a trend already over 65 years of age. We start seeing a trend of increased mortality, which really peaks at between 85 and 90. Most of those deaths will occur in the hospital or in our facility, because a lot of the patients decide, listen, I don't want to go to the hospital no matter what. I'm going to become a hospice patient, a terminal patient, rather than go to the hospital. We also see a rising trend in our Afro-American population, because this population is very prone for obesity, diabetes, and hypertension. And also between Latinos and the Afro-Americans, we work in the front lines. They work in the food industry. They work in a lot of the basic type of work where they can become easily contaminated. That's why they also have a higher incidence. And their lack of healthcare sometimes also predisposes them to greater risk. As far as gender, females slightly outweigh the males because usually the females will outlive us. They did a study in the state of Pennsylvania about Hispanic and not Hispanic. And Hispanics were a small number. And what are the comorbidities in descending order that we saw in the state of Pennsylvania? Really, dementia became the major one, followed by hypertension, followed by diabetes. And you can almost rest assured if you have diabetes, you will have elements of hypertension, you'll have elements of coronary disease, you'll have elements of chronic kidney disease. So really, these are the big players that will lead to increased mortality. And when I looked at this, hypertension and diabetes, I thought maybe I could do something to kind of help maybe see if it would diminish the rate of mortality in the patients that I was taking care of. We saw here in March the big epidemic of the pandemic in New York City, and it followed in Pennsylvania. And we started seeing our first cases in that first week in April in the home that I work with. And it kind of peaked, and we had our first peak where really we had the most severely ill patients, the ones that were really sick. And we had a second peak in May. And interestingly enough, the second peak, most of the patients that came from that second peak were almost asymptomatic. The only way we picked up on it was because one of the healthcare workers was positive in that clean unit that we had at the home. But those patients who were probably the highest risk had the least amount of illness. And now in our state, basically has kind of dwindled down, and we're going to have another peak in October or November again. So the phases, basically, we have our incubation period of 1 week where people can start shedding the virus at the end of the incubation period. And we have the emergence of symptoms. And I think it's very important for people that have, individuals that have, that take care of people in the hospital or take care of people in the homes, to have a good spreadsheet and really put all the symptoms that those patients come in with. And day to day, they should be marking as to how long their fever lasts, how long their cough lasts, how long their fatigue lasts. So when we can do data analysis at the end of their clinical course, we can have a better idea of the length of time that they had those particular symptoms. What we saw mainly is I had about 44 patients that were COVID-19 positive. Really, poor appetite was the largest and the biggest concern, because they came in, maybe they were like Dr. Carmona said, they were neurologically impaired. They basically did not even want to get out of bed. So we really had to push our nursing assistants to hydrate them and feed them vigorously so they would not decline on us rapidly. The second issue, a major issue, was fever, and about 24 out of the 44 patients presented with fever. Fatigue, about 23 out of the 44 patients. A lot of myalgias, 15 out of 44. Cough was maybe about 13 out of the 44 patients presented with cough. GI symptoms, we had about 6 patients present with diarrhea. And dyspnea was about 4 of the patients that had issues with their dyspnea. And really, the anosmia, I spotted that in 3 patients, but when we were doing our literature review with my brother and doing the analysis, it wasn't really well documented in our nursing notes, or in particularly the notes that they were keeping the track on the spreadsheets. The one thing that I noticed that was interesting was this COVID-19 loneliness, that we really felt that it was very important, because a lot of these patients, they go into complete lockdown. So that means that they don't get to see their families. They have really no family support. And as they became more ill, this became quite concerning, because families would call very concerned. The loved ones couldn't really communicate that well with their loved ones, basically because some of them were so washed out after that first week of illness that it was very difficult for them to communicate with their loved ones. The severe disease, 5 to 10% from the 14 days on, like Dr. Carmona was pointing out, then people who presented with bilateral pneumonia, oxygen desaturation, ARDS, and multi-organ dysfunction. We really only sent about 3 individuals to the hospital out of the whole 44 individuals that got the coronavirus. 2 of them expired in the hospital, and 1 of them went home. What calls my attention here is the fact that a large number of asymptomatic infections with viral shedding occurs in about 40% of the individuals. And we saw that in a lot of the workers that worked at the home, and the nursing staff or the nursing assistants that came completely asymptomatic. When we started testing people, they came back positive. That's how we picked up the second phase in May, that we picked up on one of the workers that was positive. And as soon as we started testing the patients, even though they were completely asymptomatic in the second phase, they were positive for the COVID-19. So the interleukin effect, like that Carmona had mentioned, increasing the inflammatory process with fever, ARDS, shock, organ failure, capillary leak, and elevated CRP levels. This I never got to really see at the home. The patients that began to, the 3 patients that began to have desaturate on me, I basically convinced them to go to the hospital, and that's where they ended up. Progression to late disease. That's a nice slide, because as we age, definitely we will have a greater predisposition to get sicker. I think our immune response is not as robust as it is as when we're younger. And if we're over 80 years of age, our probabilities to developing late disease about 14.6%. So as a geriatrician, when I started getting the test that became positive, and our home became inundated with the COVID-19, one of the first, we do the 5 M's, and the most important one is really what matters most for the patient. So for the patients that could have reason and make up their mind, I went to them and I said, listen, you have this illness, and there's a good probability that you're going to really deteriorate as we go along over the next 10 days. What would you like me to do with you if that would happen? And I think everyone must have been watching CNN. They said, no way do we want to go to the hospital. We would rather take our chances here at the home. For the ones that could not make a decision because they had memory impairment, I called families. So we had about four families say, well, we want to make our parents hospice. So that means they would not go to the hospital, and we would just do comfort care. Looked at their mobility. If they were walking pre-COVID-19 and they were doing fine, and they got the COVID-19 and they were really laid out in their beds, they couldn't move, they didn't want to do anything. Those people I prophylactically anticoagulated. I give them DVT prophylaxis. And I made sure that the medications that I had for them, that we tried to simplify their medication regimen, so the nurses would only go once or twice to give the medications to the patient, so their exposure time with the patient would not be as robust. And then we looked at their multiple comorbidities. That also went into our flow tables that we developed for the care of the patient. So basically, our basic orders were our weekly weights. Every Monday they would get weighed. Our nursing assistants played probably the most vital role in taking care of these patients, because they were in charge of hydrating the patient and giving them the nourishment. The nursing assistants really, I take off my hat, because they go in the mornings, they wake up the patient, they bathe them, they dress them, they get them in their chair, they feed them, and they go through that the whole day. And we made sure that each nursing assistant had maximally maybe about 5 patients. I think we had such a large amount of deaths in this country because in the county homes or the federally funded homes, the nursing assistants were taking care of 9 people. So you can imagine these people completely out in bed, sicker than the dickens, and they give these nursing assistants maybe the role of taking care of 9 individuals. That's almost impossible to do. And these people rapidly dehydrate, go into acute renal failure, and rapidly succumb. We have lost a tremendous amount of people in the county homes around this area. So our basic theme in the treatment of these patients in the continuum care communities is to hydrate them from day one. Our nursing assistants, we would put 2 8-ounce glasses of water per session for every 4 hours, and then we would make sure that they drank that. And we would give them supplements. On the average, our patients lost about 5.5 pounds in that 2-week period. As far as medications, I looked at, as I did the literature research, and saw that the COVID-19 binded to the ACE2 receptors. And that's where most of my hypertensive patients were on losartan, my diabetic patients were on losartan, and I wanted to observe whether this had a protective effect on those patients or not. I think Dr. Epstein and Dr. Murray were the 2 doctors that discussed this topic yesterday very elegantly. So we pretty much had everything that we could use here at the home. We had our oxygen, we had our, we could give them subcutaneous IV PO fluids, antibiotics. We maximized our ACE and ARB treatment on our hypertensive and diabetic patients. Our anticoagulants for the patients that had very little mobility. Almost every nursing home patient will get vitamin D3 because they don't have that much sun exposure. And we gave IV or PO steroids, especially for my COPD patients that would begin to decline rapidly. I was very liberal with the steroid use. And morphine for the patients that became very symptomatic with their dyspnea. That was very helpful. You know? And what really helped me, even though I put in the medications, a smartphone. I brought, every day that I made rounds with the individuals, I brought my phone with me. And I was able to call the families and get the families involved in the care of their loved one. And it was almost like a dramatic effect how the encouragement of the families that they had towards their loved one was like a treatment in itself. It was like giving them a major antidepressant that people, livened up. And I think that was very helpful in many of my patients' road to recovery, was to have that contact with their family. Labs, we basically did all our blood work. We drew our own blood work. We didn't have anybody come in to draw the blood work because we started seeing people that were coming in to draw blood work to the different entities all around the city. Some of them were positive, so we decided to just draw the blood ourselves, and they would come and pick it up. We were able to do Dopplers, chest X-rays, the whole 9 yards. What was important was to really do our daily rounds with family updates using video conferencing via smartphones. Our physical and occupational therapy and speech therapy department played a tremendous role because they were able to get the patients, get them moving. Speech therapy worked on their diets. If they were afraid of maybe some patients aspirating, they thickened their liquids. They gave them a special blend in their diet. That was very helpful. And every time I went in there, my nursing supervisor would make rounds with me. And she was key because she would update me on the patient's progress from the previous night, or if any events happened during the course of the night. And really, my nurses and LPNs and really the nursing assistants who were the true heroes in the patient's recovery. As far as being the physicians and my nurse practitioners or physician assistants that worked with me, we did the medical management, but basically we were just the motivators and cheerleaders for the patient's goal towards wellness. So what recommendations did I make to the home at the end of this first pandemic is that we need to have single rooms. You can't have two patients sharing a room and sharing a bathroom. That's not the way to go. Protective gear at all times. And this is going to be long-term, I think, until we're able to get the vaccine, or at least until this thing dissipates. I think that was very important because that second wave of patients that we had in May, they were my patients that were in the dementia unit. They had the dementia, they had their hypertension, the diabetes. They were the people at highest risk, yet came in the second wave with almost no symptoms. And I think part of that was because we all wore protective gear for that time. You need to have separate nursing staff, both rehab personnel and dietary for each unit. So if you bring in people from the hospital, they should be in a separate unit. Our long-term facility patients should be in a separate unit. You should keep the hospital patients that return from the hospital for rehab in an area of confinement for at least 14 days, with weekly swabbing for the staff and patients that have returned from the hospital. Basic measures such as hand washing, social distancing, and protective medical equipment is here for the long term. I did measure the immunoglobulin response on my patients, and all of them had their immune response. Now, I'm glad I did that because as the second wave comes on, and I'm going to see whether I'm going to remeasure their immunoglobulin levels, and I'm going to see if this is going to help protect them or not. So that's going to be very interesting to see if we get a new wave. One of the issues that we also ran in, initially they said, well, for your patients, in order to go home, they had to have 2 negative PCRs before they go home. And some of these patients were still testing positive a couple of months afterwards, which was almost like ridiculous because the patient was completely asymptomatic. So those rules have been changed. I think we tried to use that 14-day rule. And also, as far as the swabbing is, you can measure the cyclic thresholds. When they do this swabs, they measure the cyclic thresholds. And I think if you have a cyclic threshold over 35, it's almost going to be impossible for that patient to be able to pass that virus to anyone else. So that's a little food for thought for those people that keep testing positive, get that cyclic threshold level from your lab. I think treating patients during this pandemic has been really a very emotional experience for me. I think it really has gotten me back almost to practice hospital medicine like I used to when I was in my private practice. And our average age of our survivors was 86.36 years. And our patients that expired, their average age was about 92.45 years. Out of the 44 patients, 11 patients expired, and 8 of them were on hospice. So they were already in their terminal stage. So really, in reality, we lost 3 patients during this facility. And I did try to talk at least to one of them to see if they would go to the hospital, but they already had made their peace with the Lord, and they said, no, we do not want to go. You know, I do not want to go. I'm ready to go. So that's it. Any questions?
Thank you so much, Dr. Oscar Murillo. We are not having any questions, but what you have shown us really shows that we have to be open-minded maybe and question the old and the new, no? Because there are things that we know since always, and it seems like we have forgotten through time, just like basic measures for certain things. And the human qualities, it's interesting, for instance, in the first, I think it was in the Second World War, that babies who were left orphan died because they didn't have any caring. The babies who survived were the ones who smiled because they were touched more. And I think we have that since the beginning to the end of our lives. And sometimes we have become so strict into doing things perfectly according to how we're going to treat disease, but not people. And I think you have really made that difference. And a population that is at apparently higher risk than the rest, which is the geriatric population, can even have a good survival rate if treated accordingly, and of course, if the conditions are adequate. No? Thank you so much, Oscar Murillo.
Yeah, I think they did give me the option to do telemedicine, but I think you really need to touch your patient and listen to your patient and spend time with them. That's just, I think, a basic premise that you need to follow.
Basic humanity that we have forgotten several times. Well, and several things you show us are also, well, the difference between third world countries and first world countries. No, in Bolivia, we still have, I'm sure it's the same in India and several parts of the world. We share bathrooms, we have many people in the same room. All these things are really not helping with hygiene and everything. No? But otherwise, it's very nice that we are checking all the perspectives. I just want to make sure that if we have any other question, one question. Thank you, Dr. Murillo. I have seen that many geriatric patients have a positive RT-PCR for many weeks. What would you recommend?
Well, I think if they are asymptomatic and they pass the 14 days, I think they're going to be doing okay, to be honest with you, you know. If they get really nervous, you can always ask your lab to get that cyclic threshold and see what level they have there. They should be running that.
Question, please. Question, please.
Yes. Go ahead, please.
Dr. Murillo, very nice and interesting. Your experience with this old people is fundamental. And I want to ask you, stress undoubtedly is an aggravating factor for COVID. The patients that are in this retirement communities, they have less stress, I would assume. Do you think that would be a protective factor? And also, what happened with the Alzheimer patients? Because Alzheimer patients, curiously, tend to be very resistant because they are possibly liberated from stress in their lives. What do you think?
Well, I think in the home that I take care of, we had one nursing assistant to 4 or 5 patients. But in the other homes where they have to take care of 9 or 10 people, that Alzheimer's patient doesn't say, listen, I'm hungry or I'm thirsty, you know? So if that lady does not get to feed them or give them hydration, those patients are going to be gone in a few days because they're not going to be able to take enough hydration or nutrition, you know? That's what I have seen. And that's why I think that high death rate that we have in the homes is present. As far as the medication that with the losartan, out of 16 patients that were on ACEs on ARBs, 2 passed away and 14 survived. And the ones that were not on ACE or ARBs, 9 passed away and 19 survived. You know, so there was a you could see that it was people that were on the ARBs did it better, but I did not have a number to make it a clinically significant study. So it's going to be interesting to see what those studies that the doctor from Vancouver is developing is going to show in the future.
Thank you.
Okay. Do I stop sharing my screen now, or is that what we do? Stop sharing.
Yes, please do that. Thank you.